Recording.
Great. Good afternoon. Welcome again to another in the SMFM Fellow Lecture Series. This is our encore presentation of our research series in the Fellow Lecture Series. It is again my privilege to welcome, as his second time doing this talk in our series, Dr. Anthony Odibo from the University of South Florida. Morsani College of Medicine. He's going to discuss today screening and diagnostic testing and how that applies to research that we may conduct. This is a great talk. I've seen it before. I think it will be very valuable to all the fellows.
Thank you. Thank you, Bill. So I have no financial disclosure. Just as Bill said, I'll be talking about screening and diagnostic tests. For some of you who have an epidemiology background, this may be sometimes basic, but for most fellows, I think this is what you really need to know regarding diagnostic and screening tests. So the goal of my talk is to look at the concepts of screening and diagnostic tests, review the characteristics of effective screening tests, and then discuss how we measure the efficiency of tests that we use for diagnosis as well as for screening. And then finally look at how you use this test to refine patients' probabilities, both post-test and pre-test. And then finally also look at how do we determine the threshold of screening tests as well as diagnostic tests. How do we come up with the thresholds that are used for normal or abnormal for this test? That means we're really going to talk about receiver operating characteristic curves. So as a definition, screening tests are tests that are performed in asymptomatic populations to identify or assign probability of risk to individuals in that population. On the other hand, diagnostic tests are performed in symptomatic or high-risk population to identify or confirm an affected individual. So there are characteristics of an effective screening test that have been proposed by the WHO since 1968, and these have been refined over the years, and these include the following characteristics. The disease of interest must be important, meaning that it must have some clinical burden as well as public health burden that makes it of relative importance to be screened for. It should be easy to perform. Sometimes this can be a problem to achieve. It has to be cost effective. It has to be acceptable to patients. And then it has to be effective. There has to be an effective intervention for the disease once you finish screening and you've identified a population that is screen positive. And then the test results should be reliable and valid. This is also a big problem in that in the research environment, we do tests that are really highly effective, but when you start using them in the clinical practice, you find that they are not as reliable or as generalizable to our population as it was when the research was actually conducted. So how do we measure the efficiency of screening tests? So the accuracy of a screening or a diagnostic test refers to how the test performs in relationship to an accepted standard. And this standard can be defined by various methods which we'll cover in the ensuing slides. The test characteristics such as sensitivity, specificity, positive predictive value, and negative predictive value are commonly used as measures of efficiency of screening tests. So this 2x2 table is very familiar to most of you. So when you have a screening test, you have somebody who is either test positive or test negative. And then you have the disease itself that you're looking into. Is the disease positive or is the disease negative? And so you then have this four possible scenarios where you have a true positive and a false positive, or a false negative, or a true negative. And so you have the A, B, C, D, and you can then form your 2 by 2 table from which you can calculate your sensitivity, specificity, and your predictive values. So these are the ways we define the efficiency of a screening or a diagnostic test. So sensitivity is defined as the proportion of people with a disease who have a positive result. On the other hand, specificity is the proportion of people without the disease who have a negative result. The positive predictive value is the probability of the disease in a person with a positive test result, whereas the negative predictive value is the probability of not having the disease when the test result is negative. And we'll be doing, at least going through some examples of each of these. So just using the same 2 by 2 table that we showed earlier on, and I'll use the pointer here. So you have a test result and you have your positive ultrasound or positive negative ultrasound. And I'll be using a lot of ultrasound examples because that's my area of clinical interest. So you have your true positive and your false positive, and then you have your false negative and then your true negative. So using that same formula to calculate your sensitivity, you have to use your true positive divided by all of the positive, which would include your true positives and your false negatives. So that's how you calculate your sensitivity. So for the example here that we're giving, if there are 11 patients with a true positive and there are 2 with false negative, then you have 11 divided by 13 and you have a sensitivity of 85%. So that's pretty easy, and most of these are pretty basic to most of you, but hopefully we'll get into slightly more complex stuff as we go on. The specificity, on the other hand, will be the true negative divided by all of the negatives here. So for this example, it will be 38 divided by 38 because there was no false positive. So it will be 100% specificity. On the other hand, the negative predictive value will be the true negative divided by the true negative plus the false negative, meaning that all of the negatives. So 38 divided by 38 plus 2, which is 40. So you have a negative predictive value of 95%. Finally, the positive predictive value is the true positive divided by all of the positives. So true positive plus false positive. So in the example we've given, again, it will be 11 divided by 11. So you have 100% positive predictive value. Okay, so I hope that's clear so far. So broadly speaking, tests with very high sensitivity tend to perform well as a screening test because you really want to identify a big pool of patients who are at risk for the disease that you're screening for. On the other hand, tests with very high specificity tend to perform well as a diagnostic test because you want to have a very low false positive rate and a low rate of misclassification. So unlike sensitivity and specificity, the positive predictive value and the negative predictive value are, however, dependent on the prevalence of a disease in a population. So as the prevalence of the disease increases, the positive predictive value increases, while the negative predictive value decreases, and vice versa. And that's a very common principle to remember in epidemiology. There is another way of calculating these positive and negative predictive values. So sometimes you may not have the luxury of having a 2 by 2 table as we had in the last few examples. The approach that is sometimes used is called the Bayes theorem approach to calculating these predictive values. So you may have the sensitivity and you may have the specificity of the disease, but you may not have the predictive values, and all you have is the prevalence of the disease in the population. And so we have a formula here that can be used to calculate a positive predictive value in that situation. This is the Bayes theorem approach. And very rarely you may have to do this when you're reading a paper where they don't have all of the numbers available, and you can just go from the sensitivity and the prevalence and calculate the predictive values. So most people use the positive predictive value and negative predictive value as a way of refining risks. But another approach for refining risk is using the likelihood ratios. And this is very popular, especially in the days when we used to screen a lot for Down syndrome. And we had a lot of interest in the positive and the negative likelihood ratios of most of our ultrasound markers that we're using. So they do serve a similar function as your predictive values. They can be used to refine an individual's risk for a given condition. So the likelihood ratio is defined as the ratio of the likelihood of that result in someone with the disease compared to the likelihood of that same result in someone without the disease. So it can be positive or negative. So a likelihood ratio of 1 is non-discriminatory because it does not really help you to know those with or those without the disease. I think we'll see with later examples that the closer the likelihood ratio is to 1, the less discriminatory it is. The further it is from 1, the greater the effect of that test on the individual's post-test probability. And I think we'll talk about that in this next slide. So the positive likelihood ratio really is a function of highly driven by the sensitivity of the test. And the formula is the sensitivity divided by 1 minus specificity. And is defined as the proportion of affected individuals with a positive result divided by the proportion of unaffected individuals with a positive result. On the other hand, the negative likelihood ratio is 1 minus sensitivity divided by the specificity, or the proportion of affected individuals with a negative result divided by the proportion of unaffected individuals with a negative result. As I mentioned, the further it is from 1, the greater the effect. So what that means is if you have a likelihood ratio positive of 10, it's much further from 1 than if you have a likelihood ratio positive of 2. And it means that 10 is going to affect your post-test probability much, much higher than if you have 1 of 2. And this becomes very important when you're dealing with some of the ultrasound markers such as echogenic bowel or short femur length, and somebody comes to you with a first trimester screening result or a quadruple screen result of 1 in 65. And then how do you use the finding of one of these markers to then adjust their result? And so if you have a marker that has a very high positive likelihood ratio, then it's more likely to affect the post-test probability for that patient. So the likelihood ratios are multiplied by the patient's pre-test odds of having the disease to determine the post-test odds. So there is something we do in epidemiology, which is moving from probability to odds and from odds to probability and vice versa. And so odds sometimes, post-test odds can sometimes be almost equate to the same as a positive predictive value. But the example I just gave a minute ago of somebody presenting in your clinic with a positive result from a screening test and you're seeing a marker is one way of then using the likelihood ratio to adjust their post-test odds. So the calculating the post-test probability requires converting the pre-test probability to odds, and then post-test odds are then converted back to probability of having the disease. So for instance, if I say your risk is 1 in 10, of having something. It's really a probability of having the test is 1 in 10. But before I go back to adjusting it with a presence of a marker, I will have first of all have to modify that 10 with the likelihood ratio, and then eventually I can say your post-test risk is now 1 in 5, which is really saying your risk of having the condition is now about 20%. Patients sometimes don't think like that, but at least you have to look for very simple ways of trying to explain these complex concepts of odds and probabilities to patients. So there are the formulas we have there, which is how do you move from odds to probability and from probability to odds. So for instance, you can go from odds to the way you calculate odds is by using the probability of the event divided by 1 minus the probability of the event. And on the other hand, how do you go from odds to probability? It is by dividing the odds by 1 plus the odds. Again, these are very interesting to epidemiologists, but clinically sometimes they are very hard concepts to explain to patients. One way of using likelihood ratios that I also like is by using this kind of table here, which was published in 1975, so quite a while ago in New England Journal of Medicine. It's called a nomogram of likelihood ratios, and it goes from likelihood ratios going from 0.1 to as high as likelihood ratios going from 1 to as high as 1,000, and then from 1 to as low as 0.001. And then you look at the pre-test probability that the patient comes with, and then you then adjust their odds based on what you have with the likelihood ratio, and then you can go to the right column, this right-hand column here, and you can then go to the post-test probability. So if their initial pre-test probability was, say, 50% of having the condition, and then you now have a likelihood ratio of 10, you can just go across this line from 50, and you draw a line to 10, and then you go across that same line, and now their post-test probability is now 90% for having the condition. So that's another way of using these likelihood ratios in adjusting post-test probability. There are graphs that are published in one of the small handbook that I used to use to give this lecture to fellows and residents when I was at WashU. This is the evidence-based medicine by Strauss. Again, it tells you about how you can use your post-test and your pre-test odds, and you can go from your probability of one to the probability of the other using these graphs. And I'm going to skip through a few of them because they're not as pertinent, but one of the examples in that book, just to illustrate, had to do with the use of this pre-test and post-test odds in the case of anemia, where they looked at the serum ferritin of the patient, and in a patient who has a very low serum ferritin that's less than 15, and the likelihood ratio of, so the serum ferritin of less than 15 and a likelihood ratio positive of about 50, then there's a very high odds that this patient is going to be anemic and have iron deficiency anemia. So you're ruling them in for iron deficiency anemia. You may have to treat them with an iron. So it's just a simple illustration of one way of using this test. Okay, this is just a graphical illustration of the same principle here. I think I flipped to test. Okay. One of the things we struggle with is how do you really define the threshold of what's normal with most of these tests, screening or diagnostic tests. So the example we just gave of ferritin, and how do you know that less than 15 is a significantly abnormal level, or how do you know that a cervical length of 25 millimeters is a greater risk for preterm labor? So ideally, this is where you use your receiver operator characteristic curves, and essentially you measure a lot of people in a normal population, and then you plot them and look at what level becomes highly significant for preterm delivery, or what level becomes highly predictive for anemia. And that's so because many tests that we do in clinical medicine fall on a continuum. This is the best way of making or defining the threshold for a normal or an abnormal test. So ROC curves do display the trade-off between the sensitivity and the specificity of a test at each cutoff point. And the inflection point or the shoulder of the ROC curve is usually considered the ideal cutoff point to use. So for an example here, this is the 1 minus specificity, is the false positive rate of the test, which is on this axis here, and the sensitivity is here. So the best trade-off would be somewhere very close to the left hand of this curve. So for this example here, the ideal would be this point A here, which has a high sensitivity of almost 80%, and the false positive rate is much, much lower. So there's always that trade-off between 1 minus specificity or the false positive rate here, which is about 10 to 15% in this example here, and the sensitivity here of about 80%. So there's always that trade-off between the two in determining what's the ideal cutoff point to use for any test. So the inflection point is where there are equal number of false negative and false positive. However, the chosen threshold will depend on the purpose of the test. So for a screening test, for example, you want to maximize the sensitivity slightly at the expense of the false positive rate. So you can maybe live with a false positive rate that can be as high as maybe 20% in some situations. Most of the time we try to give a false positive rate of maybe 5 to 10%. Whereas the diagnostic test, we really want to aim at a very low false positive rate. So these are things you determine a priori before you choose the ideal cutoff point. So there is a graph here that for some reason it's not showing. Let's see whether it will show with the next. No, it did not show. What this graph was supposed to show was the Maris curve for the MCA peak systolic velocity that we use currently in determining patients at risk for anemia. Essentially, what they did there was they looked at different MCA levels and looked at the peak systolic peak systolic values of these patients, and chose a value that was kind of consistent with a false positive rate of about 20%. This was really, they were comparing this with the old days where we used to do amniocentesis, serial amniocentesis on all of these patients before we go on to do POBs. And in an attempt to avoid amniocentesis in a big population, they felt like they could live with a false positive rate of 20%. And the sensitivity at that point of 20% false positive rate in this graph was about 85%. I'm really sorry the graph is not showing for some reason. I think when we did go through the test earlier on, it did show. So it's something worth looking at later on. So as a few more words on ROC curves. So ROC curves can be used also to test for the overall accuracy of a test. So we've looked at how we use it to determine the threshold of a positive or a negative test, but you can also use it to test the accuracy of a test. So in general, a good curve lies very close to the top left-hand corner of the graph, as we mentioned, whereas a poor test will have a curve that's really close to the 45-degree diagonal line, which is almost like a useless test. The area under the curve of that ROC curve, which is the AUC, would provide a numeric value that's kind of is an indirect measure of the overall accuracy of the test. So an area under the curve of 1.0 or 100% will indicate a perfect screening or diagnostic test, and one of 0.5 or 50% will indicate a poor test, which is not better than a chance observation. So this is an example here. Essentially, you do your ROC curve as you normally would do, and then it measures the area under the curve, which is this area under the curve here. And then, based on the area under the curve, it will give you a numeric value. And if it's nearer to 100%, then that's a good test. And if it's more nearer 50%, then it's by chance. Again, this is where this diagonal line here, which is really a useless test. So ROC curves are useful when comparing the accuracy. They are also useful when comparing the accuracy of two tests. So these are easy when these two tests do not, with the ROC curves for the two tests do not cross each other. So then you can easily see from just observing and looking at it in a very subjective manner. You can look and say, oh yes, one test is better than the other. But when the two curves cross each other, then there are many other ways which you can use the ROC curve to also compare the tests. One of the first ways to look at partial area indices. So essentially, you restrict the comparison to a range of sensitivities or false positive rates that are clinically relevant. So essentially, you can say, okay, we're going to fix for a sensitivity of 80%, what is the false positive rate that each of these tests are giving me? Or the other hand, you can say, for a fixed false positive rate of 10%, what is the sensitivity that I'm getting from the test? On the other hand, you can just restrict the comparison, again, just like I mentioned, to a pre-selected value of a sensitivity or false positive rate that has been published in previous studies, and then you just want to compare this current study with those previous studies. The 95% confidence interval of the area under the curve from each of these ROC curves can also be compared. And if they appear to be overlapping, that is an easy way of saying, well, these tests are not significantly different. And if they are not overlapping, then you could say one of the tests is superior to the other. That's, again, without using any statistical comparison. But the most reliable way of really looking at this test is to use non-parametric statistical tests that compare the area under the curves between the more than one, when you have more than one ROC curves that are overlaid together. And that's a better way to really come up with a p-value that says, oh, these tests are significantly different from each other or not. Okay, so this is an example from the Bond study, which was published, I think, around 2000 or kind of early 2000s or late 90s, with Ron Wapner being the lead author. And this is the biochemistry, ultrasound, and nucleotranslucency study. So this was before the FASTA trial, essentially looking at three criteria, just using maternal age and serum measurement in the first trimester, which is this lower curve here, versus if you use maternal age alone and nucleotranslucency. And then this third curve here is where you use maternal age, nucleotranslucency, and maternal serum. So all three combined. And you can see just subjectively, without going into any area under the curve or false positive rate, you can see that this curve here, where you combine the three, it was more towards the left of all of the other curves. So it was more superior than using just maternal age and nucleotranslucency only, or using maternal age and serum screening only. So without any test here, you can see a sensitivity that was about close to about 78 to 75%, for a false positive rate here that is only about 5%. So Based on this, the authors concluded that the combined screening in the first trimester was better than using maternal age and nipple translucency or maternal age and serum screening only. So that's one way of using the ROC curves. Okay, some other factors that you have to consider when you trying to interpret the impact of a screening or a diagnostic test has to do with the design of the study. So for most studies, you want to really look, did the authors use a single reference standard or did they use different varying standards? In retrospective studies, for instance, were the authors blind to the disease condition in assigning test result? Again, going to ultrasound. So if you're doing a retrospective study and you're looking at chart review and you're trying to look at echogenic bowel as a screening marker for trisomy 21, you know you're already screening for trisomy 21, and we know also how subjective the marker echogenic bowel can be. You're looking in these charts, if you're not blind to what you're looking at, you can easily categorize more cases as being echogenic than you would do if you did not know that trisomy 21 was your outcome that you're interested in. So it creates some bias that may impact the interpretation of the sensitivity and the specificity that you get from this test. Did the study include a broad spectrum of subjects with or without the disease? Again, so selection bias can be introduced in some of these studies, and that can impact your sensitivity and specificity. But really, as we mentioned earlier on, it tends to impact mostly the predictive value rather than the sensitivity and specificity. So if you look at a study with a very high prevalence of the disease, then you have a higher positive predictive value. The sensitivity and specificity may not really be affected that much, but the positive and negative predictive values will be affected. Is the study population similar to those in whom you will be using this test in a clinical practice? This is very important. Most studies that we look at, we always look at table 1 and we try to see whether you can judge at the external validity or the generalizability of that study to your population based on what you're seeing as the comorbidity or the general characteristics of that population. The disease severity and comorbidities should be similar to those that are in your population for this test to be applicable to your population. Are the results reproducible? Again, how were the tests performed? Who performed the tests? Were they performed by specially trained MDs that have special interest in this? So there are some types of Doppler studies we do in perinatology where sometimes I may go to Europe or one of my colleagues may go somewhere and learn this specialized method, and you try to teach it to a few sonographers. But if you ask every other sonographer in the country to reproduce this test, then they may not be able to get the same result elsewhere. So these are things you always have to ask yourself when you're interpreting your study. What type of institution did the study come from? Was it a community hospital or a tertiary hospital? Most likely the community hospital may be more generalizable than in a specialized or tertiary hospital. Again, factors that you need to consider when trying to interpret some of these results. Then the study design can also influence the impact of the sensitivity and specificity of screening and diagnostic tests. So typically most screening tests are observational in nature, and they tend to be cohort studies, either prospective or retrospective. But sometimes they can be case control and they can be secondary analysis of primary studies. We have to be very careful with case control studies because we cannot use them to determine the positive or negative predictive values of a study. And the reason for that, we know that the predictive values are influenced by disease prevalence, as we've mentioned already. And also we know that the prevalence of the disease in a case control study is fixed in the process of selecting cases and control. So even no matter how many controls you're matching for the number of cases, you've already fixed the number of cases. So sometimes that creates an error that if you try to calculate your positive or your negative predictive values, then you won't get accurate results there. So just before we close, just a few brief words on clinical prediction models. So this is when you have a cluster of tests or sequence of tests that are used for a targeted disease. You want to first of all look at how these tests are derived. Ideally, you should have what we call a training or a derivation set, where you look at the test and see whether it has internal validity, that is truly measuring what is supposed to be measured. Then it should then be validated in a second or an independent population. The second population can be from the same institution, but maybe not the same people that were used as your training or your derivation set. And then the accuracy can then be confirmed if this test performs well in both the training set as well as in your validation set. So these are steps that sometimes will really give a stronger validity to a test if it's reported this way. And as fellows, it's something that you really need to watch out for. If a test is coming out and looking so good, you want to make sure that it has some internal validity as well as maybe it has some potential for external validity. When screening tests include multiple variables, sometimes some of these variables can have different impacts on the overall effectiveness of the test. So as an example, let's say you're doing a population study on what factors can predict the outcome of fetal growth restriction in a population. We know that there are many individual factors like race that can come into a race, smoking, constitutional factors. But the question becomes, if you're trying to form a clinical prediction value where you're looking at how many of these multiple factors influence the outcome that you're looking at, you want to see that each factor has an equal weight rather than one of them really driving the outcome that you're looking at. So there are statistical methods that you can use to try and weight for different factors. One of the methods that can be used is called principal component analysis, which is a little advanced for this talk. Another method that you can use will also be advanced for this talk, but also all of these are statistical methods that you use to try and look at least try and make it an equal playing field for most of these factors that you're looking at. Or if they are not equal, at least you're giving equal weighting, or at least the weighting that you're giving to each of these factors is based on their individual contribution to the final prediction value for the outcome of interest. So this is something that's a little bit more advanced, but again, it's something that you see a lot in the literature. So in conclusion, screening and diagnostic tests are common in perinatology. Understanding how test results are calculated and how they are interpreted are essential in applying this to your patient population. So I'm going to stop here. Sorry you could not see my face, but it turned that we had some technical difficulty whereby if I click on and you can see my face, then you won't hear my voice. one of the methods that can be used is called principal component analysis, which is a little advanced for this talk. Another method that you can use will also be advanced for this talk, but also all of these are statistical methods that you use to try and look at least try and make it an equal playing field for most of these factors that you're looking at. Or if they are not equal, at least you're giving equal weighting, or at least the weighting that you're giving to each of these factors is based on their individual contribution to the final prediction value for the outcome of interest. So this is something that's a little bit more advanced, but again, it's something that you see a lot in the literature. So in conclusion, screening and diagnostic tests are common in perinatology. Understanding how test results are calculated and how they are interpreted are essential in applying this to your patient population. So I'm going to stop here. Sorry you could not see my face, but it turned that we had some technical difficulty whereby if I click on and you can see my face, then you won't hear my voice.
Oh, maybe we lost his voice too. Well, I'm not sure if we still have Dr. Odibo, but thank you very much for that talk. If you do have questions, you can type them in to the question and answer tab below, and I can forward them to Dr. Odibo. I'm sure also he'd be very happy to contact you by email if you had questions pertaining to the talk. Again, just a reminder, first and third Wednesdays of each month continue to be the fellow lecture series, and hope everyone will continue to join in. I'll give it a minute, see if he's back on. Oh, hey there. Yes, great. So I
Okay,
just
thanks.
put out a call to see if anybody has any
I'm back on, right?
questions.
Can you hear me now?
We'll give that a
Okay.
second to see. I think it was a great talk. Thanks very much for that talk again. And I guess if we don't have any questions, we'll send Dr. Odibo back to the beach there in Florida.
It's raining. It's raining.
So we'll see everybody.
Okay. Bye-bye.
Bye. You guys have a great afternoon. Bye-bye.